Hi, and welcome to the show. Rate and review at kevinmd.com/rate. Subscribe at kevinmd.com/podcast. Today on the show, we have Peter Hetzler. He's a plastic and reconstructive surgery resident. His Kevin MD article is titled The Impact of Hand Surgery on Human Identity and Expression. Peter, welcome to the show.
Thank you for having me. I really appreciate it.
So we'll get into your article in a little bit. First off, briefly share your story and journey to where you are today.
Sure. So I grew up in New Jersey. I'm a son of a plastic surgeon and a ED nurse. Sort of went through high school and college and med school all in the New England area. And then found myself at the Georgetown Plastic Surgery Residency Program, where I've developed an interest in hand surgery specifically. And we rotate at Union Memorial Hospital, which is where the Curtis Hand Center is. And during my time there, I sort of became really interested and passionate about hand surgery, and not specifically the surgery itself, but also just the way you interact with patients in a way that is a little bit different than other aspects of plastic surgery.
Yeah, how so? Tell us more about that. So that interest in the hand, how does that differ from the interactions with other patients?
Yeah, so I think, in a lot of other sort of clinic scenarios in plastic surgery, patients generally come in knowing what's going on and what they want. So for example, someone may come in with large breasts, they want a reduction mammoplasty, and all we need to do is make sure that the indications are appropriate and they're a good surgical candidate. And that's really not true for all sort of plastic surgery clinic scenarios, but I found that especially with some breast cases and other things like that, you weren't doing much of sort of the history and physical that you would normally learn about in medical school. But in hand surgery, someone comes in and they have nonspecific pain in their hand or something else going on in their upper extremity. And you sort of really have to dig in, get a full history, do a full physical exam, and you can actually really figure out what is going on with the patient just with those two modalities, and sort of the classic teaching of how important the history and physical is. And so that really sort of spoke to me once I was dealing with these clinic patients in the hand office. And the other thing that I really liked was I worked with surgeon Dr. Ryan Katz there, and he has such a focus on the psychosocial component of how hand injuries and hand problems affects these patients. And that really spoke to me as well, and sort of led me to sort of think about how hand surgery and hand issues really impact the human experience and human identity, which sort of led to the article that I wrote.
Yeah, we're going to talk about that article. But before I do, for those who aren't familiar with hand specialists, so give us a sense of the complexity and the nuances specifically with the hand.
Yeah, so a lot of times hands are one of those things where really no one is going to sort of deal with them or touch them in any specific way unless they're hand surgery trained. It's one of those areas. It's kind of like the face in that way, where you really people will sort of send it to the specialists. And another thing about the hands is after the face, it's the second people will look at to determine if someone has like a normal appearance. So people really focus on not only how the hands move, but how they look. And then the other thing about it is it's any problem with the hand, bony, soft tissue, malignancy, basically anything that's on that area, forearm to hand, it's going to be sort of taken care of by hand surgeon. And so when you do your fellowship, you sort of learn all the various aspects of it, the vascular, all of it. And then the problems that the hand has can be anywhere from not very non-specific pain to, full amputations. So you sort of run the gamut of all the surgical complexity and honestly sort of medical complexity of doing injections in clinic, doing conservative therapy with splints, and sort of referring to psychologists and pain management specialists for these patients who have had trauma to sort of learn how to deal with and come up with coping mechanisms to help them get through this hand issue. Because a lot of times surgery is really not the right thing for them. People will come into our office and say, hey, you guys are hand surgeons. I want you to fix me with surgery. And it's really our job to, one, determine if surgery is even an option for them. And two, if it's not, really talk to them about ways where we can help them that are non-surgical. And that was another part of hand surgery that I really loved was, yes, we do surgery when needed. But on the other hand, it's a lot of having a conversation and determining, why these patients are feeling this way, what else is going on in their life that may be, depression, anxiety, chronic pain, those things. And it all sort of comes into one global picture about the patient, and you come up with a plan for them based on that.
All right, let's talk more about that in your Kevin MD article. It's titled The Impact of Hand Surgery on Human Identity and Expression. So you were going into it a little bit earlier. Tell us more. How did this article come together?
Yeah, so like I said, I was a second year resident, currently a fourth year now, and it was my first time at Union Memorial, and we take a fair amount of hand call there as a junior resident. And I was taking a hand call on I think it was a Saturday, it was some weekend day, and we got a message from the chair, Dr. Higgins, about a plastic surgeon in the DC area who was coming in with what sounded like a median nerve laceration on his dominant hand. And, that's like for any surgeon, that's devastating, So the patient ended up coming in, I evaluated him. And one of the first things, before I even started the interview, one of the first things that that specific physician said to me was like, be honest with me, like, do I need to find a new profession? Like, do I need to change what I've been doing? And it's just, I think that moment sort of spoke to me on how precious and how influential the hand is into someone's identity. And, I talk about this a little bit in the article, in a society like the United States where work and identity are so related, it's a capitalist society, and sort of your identity, your career, all of these things, when you meet people for the first time, you're saying, oh, what do you do? And so because your identity is so tied to what you do and how you interact with the world, the hand is just so important to that. And, one of the big jobs that we have in America is manual labor. That manual literally comes from the Latin, meaning hand. And so I talk a little bit about that in the article. And I go on to say, because we are doing surgery and we're literally limiting the hand, after surgery, we have to immobilize the hand, we have to put them in splints. And we're sort of literally taking away their ability to interact with the world, patients to interact with the world and express themselves. And that's going to just depress how they interact with people, how they see the world. And so any sort of underlying chronic pain, depression, anxiety, we talk a lot about how people who are on workman's comp and they have legal issues going on, a suit going on, the outcomes tend to be pretty bad until that suit is done. And once the suit is done and the patients don't need to worry about it anymore, their rehabilitation and their outcomes start getting much better. So there's this tie between sort of the psychosocial impacts of what the injury is and the injury. So we can cure the injury, we can fixate the bone, we can close the soft tissue. But if there's a disconnect and the patient is having other stresses and doesn't have the ability to sort of cope with the disease process, cope with the trauma, they don't have a support system, the outcome is going to be so much worse than someone who does have those things. And so through my interactions and working at the Curtis Hand Center, they have a psychologist on staff in the office specifically for these reasons. And so that whole journey that I went through as a second year really showed me how important, not just when you're a surgeon, not just being able to operate, but being able to recognize and identify these things and then knowing the right routes, the right things to say, the right pathways for these patients who need additional help rather than just surgery.
So walk me through this psychosocial process in your hand clinic, because as patients, they may not even be aware about how directly correlated their upcoming hand procedure is to the various psychosocial things that you just mentioned. So walk us through that procedure. You said you mentioned that you had a psychologist that kind of talks to them about the potential impacts. Yeah, just walk us through the process beginning to end in terms of how you incorporate some of those psychosocial implications into their upcoming hand procedure.
Yeah. So, a lot of times, when you walk into the room, and Dr. Katz talks about this, and I've sort of learned from him, when you walk into the room, you can almost immediately tell, and any physician will know this, you immediately walk into the room and you can get a sort of a sense about the patient's demeanor, how they're feeling, how they're interacting, and just basic social cues. When you walk into a room and you talk to a patient, you're like, hey, how's it going? How are you? Normally, a normal social interaction is, hey, doctor, so-and-so, like, I'm doing well, I have this thing going on. And other times when you walk in, there's something off about the interaction. You say, oh, you walk in, hey, how you doing? Well, I've had this thing going on for such and such time, I just need help. Something clicks where you're like, okay, this, there may be something else going on. Now, it's not always the case, and you certainly don't want to put any bias onto these patients who may need help, but it's something that just clicks your mind on and say, okay, there may be something else going on that I may need to pay attention to. Now you do the normal history and physical, and you do all these things. And let's just say somebody comes in with non-specific hand pain that we can't really help with surgery, because a lot of times surgeries will just make it worse. If we're trying to treat pain with surgery, you got to be very careful about that, and you have to make sure the indications are right. And more often than not, there are no indications for surgery. So if somebody comes in with non-specific hand pain, do a whole history and physical, you then sort of just you inquire about, what's going on. Hey, do you have help at home? Like, how long this has been going on for? Do you have any history of mental illness, depression, anxiety? Do you feel safe at home? If it's workers' comp, is there litigation going on? So you just need to take a step back from your surgeon sort of viewpoint and really get into understanding what is going on at home, how work life is. Are there any additional stresses, drugs and alcohol, anything that may change their ability to cope and deal with a problem or pain? And then once you sort of interrogate that, figure out, they may say, no, nothing. You say, well, surgery's not really good for you. We can try some conservative measures. We can try injecting some steroids and see how it goes. And then you can come back and we can continue our conversation. Or if you identify some of these things, you can offer, we have this psychologist who helps with these things with chronic pain, specifically with the hand, with determining some good coping mechanisms, and you can offer that to them as well. And that's sort of the flow and the way that you can think about, these patients that may have a more complicated sort of psychosocial situation that you sort of really need to drill down on, because that's what's going to really help them and get a good outcome rather than just operating on them.
Now, how about in a primary care setting? What are some common hand issues that primary care clinicians like myself may see in a clinic, and perhaps cue us in now in terms of some of those psychosocial impact of common primary care hand conditions?
Yeah, I think, arthritis, rheumatoid arthritis, osteoarthritis. The most common one is, thumb CMC arthritis. It's very common. Obviously, there are surgeries that we can do for that. Non-specific ligamentous soft tissue injuries. A lot of times people will come in and say, I've had this pain for, years or whatever. And I can remember that I had some sort of trauma, and then it kind of comes and goes. There's sparks and pains. And a lot of times we end up just saying, we can try these, consider like a splint or anything, but you are going to sort of have to learn to live with this pain. Ligamentous injuries heal much slower and not completely compared to bone. And they're the ones that sort of linger forever for the rest of your life. And, I myself have some like ligamentous injury from running track in college and those things. And I still get pain in there. And it's one of those things that like you just won't ever get rid of. And I think some patients have this idea that we can get rid of pain. Like pain is something that we can get rid of. It's what we're here for. Doctors should get rid of pain. And I think it's really important early on in the clinical encounter to really be upfront and be like, look, we don't operate for pain. That's not something that we can almost always, we can't get rid of pain 100% of the time. It's something you may have to live with for the rest of your life and sort of come up with mechanisms to deal with that. We can certainly help along the way, and we won't abandon you in any way, but it's just the reality of the issue or the trauma that you have.
Now, what kind of symptoms would require us to refer patients to hand specialists like yourself?
Yeah, I think obviously anything that you all don't feel comfortable with, we're happy to see. I mean, we trained in this, so we are absolutely happy to see. I think anything that causes a functional deformity, so anything that limits their ability to use their hands, any masses, that you're suspicious of, pain that is sort of anything that's really going off in your head, like, I've seen a lot of this stuff, but it just doesn't sit right with me. Obviously, any fractures, we're happy to see.
What about ganglion cysts? Because those are actually the most common things that I see.
Yeah, I mean, ganglion cysts, it's something that, so there are a couple different options that when we see a ganglion cyst, we say, hey, this will come and go. We can take it out if it's bothering you. We can also try and sort of use a syringe and suck out all the stuff and see how, and put you in some compression and a splint and see how it does. We can do surgery. We can do nothing. So I think if they have a ganglion cyst and you're thinking this is a ganglion cyst and it does not bother the patient, they're totally fine with it, it doesn't cause any functional deformity or any pain, we don't need to see it, and you should feel comfortable, just having them come back if they have an issue. if they want surgery, they want something done. If it causes functional deformity, pain out of proportion, and it limits their ability to move, that's definitely something that we should see, because we could take it out, or we could, suck it out or whatever.
Now, how about specific questions that we can ask patients in the exam room, again, to inform them about the psychosocial implications of their hand condition? What specific questions do you ask, or what specific questions should we ask patients?
I think getting a history of any, pain syndromes in the past, do they feel like, do they have do you have a high or low pain tolerance? I think just asking general questions about their mental health, do you enjoy things, the normal sort of depression screen? Do you enjoy things that you normally do? Do you feel safe at home? Do you have support at home? I think anything to get a sense of what their social support is, and sort of their, honestly, any way to sort of get an idea about how their ability to cope with things and understand medical issues. I think getting a sense of their medical literacy can be helpful. And I think talking about how their pain is something that, unfortunately, based on certain traumas and things, that you're just sort of always going to have. And you can mention, like, we can certainly send you to a hand specialist, but they're probably going to say the same thing. And so I think just trying to get a sense of their background, their support system, how they sort of think about issues, or how they've dealt with medical issues in the past or medical problems, can sort of key you into how they may deal with pain or trauma or those sorts of things.
We're talking to Peter Hetzler. He's a plastic and reconstructive surgery resident. His Kevin MD article is titled "The Impact of Hand Surgery on Human Identity and Expression." Peter, tell us some of your take-home messages that you want to leave with the Kevin MD audience.
I think a big take-home message that I'd like to say is that, I think historically surgeons have been known as tacticians. They sort of have poor bedside manner. Everyone sort of knows the stereotype about that. And that's not to say that there are surgeons who are like that 100%. And there are people like that in every specialty. But I think the take-home message I want to see is surgery is a lot more than just operating. It's having a conversation with your patient, developing trust with your patient, and really determining if surgery is what is in the best interest of the patient. You really have to drill down on the indications of this procedure, because it's easy to operate, but it's hard to say no. And that's probably the most important, is learning how, when surgery is not the best option, and helping your patients through that decision-making process. And once it's done, we may not have surgery. We may not be able to offer surgery for you, but we have these other things. We can send you here. We can see you back in a couple of weeks, see how you're doing. I think that's something I definitely want to sort of have take home, is surgery is more than operating. It's sort of a whole perspective on the patient, and determining, if it's indicated, absolutely. But it's a much more delicate and nuanced sort of decision-making about when surgery is not the right thing. And our indication to operate, we should be on that. Always when we see a patient, our thought is, I do not want to operate on this patient. And through the conversation and the history and physical and everything, it should convince us to operate. We shouldn't go in thinking, oh, we're going to operate, and then convinced not to operate. It should be, we're going in not to operate. I'm convinced that this is the right thing for the patient. They understand the indications, the risks, the benefits. I understand those as well. We come up with a surgical plan that we're both happy with and we're both confident with, and sort of have the right expectations for the outcome of this procedure.
Peter, thank you so much for sharing your time and insight. Thanks again for being on the show.
Thank you so much. I really appreciate it.